Welcome to Destination Change, a podcast where we talk recovery, treatment, and more. I'm your host, Andy Fiedler-Sutton with the National Behavioral Health Association Providers, and I use she, her pronouns. My guest today is Robb Layne. Robb Layne, he, him, is the Executive Director of the California Association of Alcohol and Drug Program Executives, the only statewide association representing the full continuum of substance use disorder treatment and recovery services in California. Robb has played a central role in transforming the association into a major force in the SUD policy arena, strengthening its financial position, broadening its membership impact, and significantly expanding its visibility and policy footprint on behalf of providers across the state. Graduate of the University of California, Davis, Robb has built a career defined by public service, strategic leadership, and a deep understanding of California's health and human services landscape. His professional path has spanned multiple sectors, giving him a unique ability to connect policy, operations, and real-world systems change. He began his career in the California State Assembly and State Senate, where he has spent more than a decade serving at the legislation and committee staff. Robb brings a deeply personal perspective to his work. As a parent of a son living with serious mental illness, he understands firsthand the importance of responsive, compassionate, and effective behavioral health systems. That lived experience informs his advocacy and leadership, grounding his policy work in the realities faced by individuals and families navigating care. Welcome to Destination Change, Robb.
Thank you for having me. I appreciate being here.
Now, longtime listeners are going to know exactly what my first question is, because it's the same question for everybody, because I'm always interested in hearing kind of what I call origin stories, basically how you got into the business, why you chose this versus, say, accounting or entertainment. There's a billion careers at that. What made you decide to go into this?
Yeah, it's interesting because I don't think a lot of people choose this business. This business chooses them. I feel really strongly about the people that I work with, whether it be my staff members at CADP or my colleagues that do statewide policy, that they find something or something found them that called them really to work in this space. I actually, like you just said a second ago, started out by working in the Capitol, and I had a list of wonderful mentors that really inspired me. Somebody that really sticks out would be then Assembly Member Wesley Chesborough, who actually made it part of his policy book to represent people with disabilities. And part of what I did is help advise him on policies related to people with developmental disabilities, and this was back when mental health and substance use disorder was qualified as a disability, right? It's super interesting context. And so when I worked my way through the Capitol, I found that it was something that was really, really, really important for me. I have lived experience around family members who have a substance use disorder. So at that moment, when I was in my young 20s, I was really able to marry this person that was wildly inspiring for me, this great assembly member that was wildly celebrated for being this leader in this field. And then also it was able to sort of dovetail with the experience that I had. From there, it was an interesting sort of navigating my professional career, because how do you make a business? How do you create a career around, well, I'll call them safety net services? And I found that there's an entire group, there's an entire career path, there's an entire community of individuals that are basically driving advancements in substance use disorder, in Medicaid services. In California, it's Medi-Cal, in mental health services. And so I was really able to sort of help navigate that. I worked at the County Behavioral Health Directors Association. In California, the counties play a major role in providing care. And about 3.5 years ago, I was recruited to lead CADP. Now, CADP is the California Association for Alcohol and Drug Program Executives. But that really is just short for, we're the people in California that represent providers who keep people alive to make sure that they have a second chance, to make sure that they can receive community-based, robust treatment. So that's what we do, and that's how I got into it.
Okay. I always like to ask also with people who are executive directors, I know there's no such thing as an average day. To put it bluntly, what exactly do you do?
What do we do? It's interesting. When I first started this job, I think about things from like a pie chart perspective. And this is an executive to executive sort of like thought and strategy. When I first started my job, my pie chart was mostly like, oh my gosh, this issue's on fire. What the heck am I going to do? How am I going to solve this problem? A small sliver was like, maybe thinking about what the next day was going to look like. And then a very, very, very small sliver was like just me doing my job without any emergency. So, the first part of my job, because there was so much to do, was really heavily weighted in a lot of these fires that we had to put out. But I work every day right now to do really a third: strategic planning, dealing with whatever emergency we have in California around substance use disorder. And then the third is really just trying to do payroll, meet with staff development, making sure that people that I'm working with have me as a resource to them. I think that one of the biggest things that I do for staff is just hiring the right person, getting out of their way, and helping them remove barriers. So that last third is really more about that.
Awesome. Yeah, I'm a very big fan of bosses that trust their employees. having had bosses that have not in the past.
Yeah. And it's also interesting because within each one of those thirds, there's these really sort of interesting and stressful things, right? So that could be negotiating legislative amendments with my policy staff on a piece of legislation that we're trying to put forward. Keep in mind, California is a full-time legislature. So we have a lot of activity around statewide policy and regulations, or meeting with the department, or, figuring out that there's a new regulation coming out that, our state department's wanting our opinion on. So, some of that stuff is super interesting, but it's also, high stress.
Yeah. You're not my first advocate on the list. I've interviewed Andrew Kessler, our advocate in Washington, D.C. was one of our prior interviewees. I've also interviewed a couple others, people who do advocacy. So I kind of know what you're going to say with this. Advocacy, especially nowadays, is becoming more and more important. What would you say is the biggest kind of hurdle for getting advocacy going?
Stigma, fragmentation, and the political will. So when we think about substance use disorder and we think about overdoses, the issue that I think keeps getting missed within our space is the most vulnerable amongst us have already overdosed and died. When it comes to California politics, a lot of people just feel like their job is to help individuals who are in need of services, but they don't necessarily think that their job is the call to action to get involved to change statewide policy. I also believe that the consumer voice isn't centered as much as it should be. So one of the things that we believe at CADP, and one of the things that my board and executive committee feel really strongly about, is the person closest to the problem is the person closest to the solution. So how are we within this space creating an opportunity for those who have lived experience, whether they're at the beginning of their journey of recovery, they're far enough away from chaotic use that they can be involved in advocacy? How are we making sure that they're the ones that are putting forward the policies that are affecting the services that they are trying to seek? How are we providing robust community care? All of the details, whether that be federal funding, FFP, all of that stuff needs to float into the background, right? Nobody cares how things are paid for. They only care if the services that they need are working for them.
So, yeah, we've talked about stigma before and how that's one of the many hurdles people call. One of the reasons this podcast is called Destination Change is because we are big on recovery capital, and that recovery is a journey, not a straight line. Other than stigma, what would you say are some of the other hurdles that you've seen that are present nowadays for people to kind of stop them from moving forward easier, I guess is the best way to put it?
Yeah. If I get back to the hurdles question, can I re-loop back on the stigma issue? Because I want to make a couple of points on that before we move forward. I think that the traditional idea of stigma is limiting us as a system. I know that people think of stigma around, shame around accessing services, shame around telling their story. But I want to think about stigma around the perspective of administrative burden, insurance decisions, paperwork reduction, and those kinds of things. So when you think about your experience, you go to your primary care doctor, and I love my primary care doctor, so this is not me making anybody a bad guy here, but you go to the primary care doctor, they have a little bit of a conversation between the two of you, they maybe do a screening and they check a couple of boxes, and then you go and you leave, and the doctor goes off to the next person, and all of the the information that is discussed during that visit, it's sort of put into the computer as you're going, and you can sort of go about your day. That is not the experience that people who work in substance use disorder have. They have to fill out so much paperwork. They have to be so creative around the screenings that they're doing. many of the people that I work with, many of the CEOs that run these life-saving programs have to spend more administrative time to bill for services than their primary care peers. So I think stigma around that is really, really important. I also want to call out the stigma around fraud, waste, and abuse. There is this feeling in the services that we're providing that providers are not doing the right thing. And it's really driven by these news stories of these bad actors. But the reality of it is that there are providers out there that are saving people's lives, that are doing things from a mission-centered perspective, and that are just absolutely crushed with all of these audits, that are absolutely crushed with all of this unnecessary paperwork. So how do we basically remove these types of administrative things from these providers so that they can basically do the work, they can treat the person and not treat the paperwork? I think that's a really important thing for me to think about, because if I'm going to spend $1 on healthcare in the primary care setting, let's say I spend 10 cents on the administrative stuff. In the substance use disorder space, it's not 10 cents. It's not 20 cents. It's much, much more. And it's more not because it requires us to do extra work, because it has more stigma. And that's a really important thing that I want everybody to understand. It's expensive, it's unnecessary, and it's totally redundant.
Mm-hmm. I mean, government.
What do you think about that?
Who'd have thought? But yeah, no, that's definitely a thing. Now, normally, when I talk to substance use, I typically stay to that. But, we are obviously the National Behavioral Health Association providers. Yeah. You mentioned behavioral health. Let's talk a little bit of kind of like the intersection of substance use and behavioral health and how that affects what you do.
I don't know if you did this right or if you did this on purpose, but that actually frees me up to the fragmentation sort of barriers thing that we were talking about a second ago. So thank you for that. We have a really exciting time happening right now because there's a lot of attention on what we're doing from a national perspective because of homelessness and because of the fentanyl crisis. Our president has done things like named fentanyl as a weapon of mass destruction. So a lot of people that are, that wouldn't normally understand that product, that substance, they now understand that it's poisoning our drug supply, right? It's also interesting in California because a lot of people, they say behavioral health, but they really just mean mental health. The other part, the other barrier, the other fragmentation, the other sort of dynamic that we're struggling with is the substance use disorder space hasn't had as much traction or forward momentum as mental health. And so if we start to bring in mental health into the substance use disorder space and call it behavioral health and start mixing and intermingling funding, the mental health community is much more advanced and much more professionalized around applying for grants, standing up programs. And so now, we're really sort of competing with our own to figure out who's going to get the contract, who's going to be able to provide these services. So I think one of the things that we really have to figure out right now is, if we do want to fully and meaningfully integrate behavioral health, how do we essentially allow substance use disorder providers to catch up to what mental health providers have been doing for the past couple of decades, right? So there's that within the provider perspective. We have right now in California a lot of really great leaders, right? One of the leaders that I have as a colleague, which I'm so grateful to have, is Gary Tsai from LA County Department of Public Health. And he is doing a lot of amazing work around the professionalization of staff, right? We have these change makers that are essentially saying, this is what our current system is. And I want to get us to over there along the horizon. And how are we going to create resources? How are we going to create funding? How are we going to make sure that our employees have the resources and the training they need to further professionalize the work that we're doing? In California, we're now doing things like enhanced case management, where we're contracting with health plans, and health plans are accustomed to contracting with providers who have a certain level of education and training. So how are substance use disorder providers going to act more medical? How are we going to get our staff to have more medical training? That crosswalk is sort of trying to happen right now. And we're doing it, and we're going to get there. It's just a lot of work. It's a heavy lift, as some people would say. So I'm just really grateful that we have these individuals, and it's not just me. It's all of these people in the state that are like, no, we want something better and we demand something better.
That is a great plan. Some of the things that was on your bio that I didn't mention is that you had served on the Sacramento LGBT Community Center and you are married to Mark Hoensberg. So obviously, LGBT issues are important to you. My wife works at the LA LGBT Center. And so I know that there's been a lot of stress and a lot of issues coming around. Talk a little bit about kind of that aspect of your job and how you fit that into it.
Yeah, I want to call out that the work that I do, and I am a gay man married to Mark, and I believe that one of the most important decisions you make in your entire life is who you share it with. When I think about, the person I'm married to, I'm so grateful to Mark and I'm so grateful for the support that he gives me, but also he pushes me in a really, really amazing way. And I want to say that that's part of my story, but it's also so deeply who I am. I'm also a gay Jewish man, and I am the board chair of the Jewish Federation of the Sacramento region. And that plays a factor into what I do. I am a white man, and I'm also in some ways a double minority, right? So I represent as somebody that has a tremendous amount of privilege, but it's flavored with me feeling sometimes very, very, very other. Part of the work that I try to do is essentially create space for people who need to have their voices heard and just get out of their way, which goes a little bit into what we were talking about with the larger consumer movement. The other part that I'm really trying to figure out, I don't know if any of your listeners are out there and they want to connect with me and we can sort of troubleshoot this. How do we successfully create space for individuals who have lived experience that needs to be appreciated from a cultural perspective without tokenizing and resourcing them so that they can have their voice be heard in an appropriate way? Every industry is shifting. We have the people that have done the hard work to get us to where we're at. And then we have these new emerging leaders. I'm thinking about like these individuals that are thinking about things in a different way. And so how do we really merge that? That's how it plays in. It's like, how do we create space for these people so that they feel like they can bring the things that make them who they are to this space? And how do we merge that in a significant way so that it's meaningful? Also, at the same time, we should have done this 10 years ago. And so there's that sense of like, how do we do it from a change perspective and, slow and modified and structurally safe, but then also like, come on guys, we should have done this a long time ago. Let's keep up.
Mm-hmm. We already talked about stigma a bit, but what would you say is the biggest change you've seen since you started working in terms of the industry?
Let's see here. When I started this work, I thought that the biggest barrier was funding. And the truth is that it's actually not funding. It's something that is far more upstream, and it's legitimacy. A lot of individuals who have a substance use disorder struggle with it being respected as a medical issue, as a medical disorder, as something that is treatable with medication. I constantly have to fight, professionally, with people who say things like, well, they need to hit their rock bottom, or this bootstrappy stuff that it's like if somebody had enough willpower, they could just sort of dig themselves out of the depths of their disease. That's not the way it works, people. And I think half of that is education and half of that is just creating this larger space where what we do is a legitimate medical service. One of the things that we're working on right now is just people's ability to have access to medication-assisted treatment. There are medications out there that are not just, Narcan and naloxone that save people's lives by allowing them to live with a substance use disorder and treat it with medication. And that wasn't available to us, decades and decades and decades ago. So there's a little bit around medication-assisted treatment, legitimacy. There's also a little bit around, the legitimacy of the work we're doing, which I mentioned a few moments ago, professionalizing our workforce. And I think there's a lot of education that we really need to do. We have a lot of partners on this. And I think that they're doing the work at the local level. But the other part, I think, is helping individuals who are doing the good work at their programs lift it up as a best practice so that we can share it with the state. If you don't tell people about it, you don't get credit for the good work. And so many providers out there like Tarzana and HealthRight and others, they're just doing the work and they're not telling people. So that's part of one of the biggest shifts is that it's no longer good enough just to do the work. And now you have to do the work And you have to have this whole social media presence and relationships with your elected officials because those who are in the Capitol are fighting for funding.
Yeah, you got to have your own brand, as unfortunately everybody has to have their own brand, as they like to say.
That's right.
Now, the industry is obviously changing, sometimes on an hourly basis nowadays, with what's going on in the world.
Bag stamps the cuts.
Exactly. Is there any way you can kind of give me an idea of where you think the industry is going to be going in the next few years? Or is it kind of just, we're playing it by ear?
Yeah. I think that we're losing hope because there are so many things that are happening, right? I was talking to somebody a few days ago and they were saying, we live in unprecedented times and I'm exhausted because of it. So I know that things will continue to improve because we have people that will make things improve, like you, Angie, and other community leaders, both at the California and other state perspective. So I think that's really important. In California, we are significantly investing on the consumer voice. I would be happy to share more with you later on, but CADP is in the process right now of standing up an entirely separate nonprofit called Substance Use Disorder Voices for Change that will be a completely consumer-focused association. So keep an eye out for that. We are going to have in California consumers that are going to be at the testimony table at their local boards of supervisors and at the California state legislature that are going to be educating members, not lobbying, but educating members on their experience, on the services that they feel like they need to sort of insert in the middle of these policy conversations. We also are putting together this entire leadership academy for these consumers to make sure that when a board or commission or the governor says, I want a consumer on the Proposition 1 commission, there's a consumer that's ready, that is trained on how to run a board meeting or how to vote or how to do research before you vote on something. So I really want to say that that's something that we're contributing to the system, that the CADP board and the CADP staff and the executive committee have said, no, we can do better and we will make significant time and money investments in this. We're doing that in partnership with the Department of Healthcare Services, and it's a super exciting project. Secondarily, more around the professionalization of the work that we're doing, right? So what does that look like? I think health plans are going to be contracting with providers, and the state is making a significant investment into the continuum of care. It is no longer enough to just provide this one service and think that you're going to be able to continue to do business in that way. You are going to have to start providing a continuum of care. And that's going to have to include substance use disorder services for people who aren't currently doing it. So I think that the reimbursement models are going to start to shift. I think that the licensing is going to start to shift to accommodate these types of things. In California, we have like crisis services, physical crisis services, but we also have things like 988 from a national perspective. So individuals who are on the streets or in the middle of a chaotic event, whether that's a chaotic drug use event or in the middle of a mental health event, there's crisis services that will come and stabilize them and help sort of transition them to care. Like, that's really exciting. Where are they going to go, right? Emergency departments are not the best place for people who are having these intrusive thoughts. And so we're partnering with the hospitals. We're partnering with primary care doctors to make sure that if anybody is being screened for these types of chaotic events, that we could sort of bring them into care to do that early diagnosis and that early intervention earlier. Like I said, we're partnering with the hospitals to essentially say, how can we, when someone is brought into care through crisis response, how can we make sure that they go to a sobering center like Janus of Santa Cruz? They're doing some amazing work around sobering centers and emergency department diversions. So I think there's going to be a lot of transformation in this space of just like the dignity of people with substance use disorder and the funding. This may sound like overly highly technical, but unfortunately, this is how it works.
Yeah. And you've mentioned leadership a couple of times, and we kind of broached this already, but I'm going to give you a softball question. What makes a good leader? In your opinion, what makes a good leader?
I think I said it earlier. It's just hiring the right people and getting out of their way. It's keeping in touch with your board and the community and having a measured approach to progress. It takes a lot of money to look this cheap. That's a quote that Dolly Parton said a long time ago, right? It's a really important thing that I think about. And the reason that it applies to what I do is it essentially says, in order for me to get here, you have to be very, very prepared. And so, it may just look like, people can show up and talk off cuff and just sort of like it seems effortless, but it really is not. So actual leaders make it look easy, but it takes a tremendous amount of preparation to do that. The other part that I really feel strongly about, and my grandma Pat used to say this, what's right is right.
Mm-hmm.
In my life, I have been in the thick of a lot of political projects. And the one thing that I think leaders really have to keep in mind, have to be keeping as their true North Star, is what's right is right. You can't listen to what people say and adopt that because it's the easy decision. Sometimes you're going to have to make hard decisions, and that's literally part of your job description. So don't lose track of that.
Mm-hmm. Yeah. Part of my background, for some people I think already know this, is I spent 15 years or so volunteering with community theater.
Yeah.
And I stage managed several times. And that's very much a job of, if you do your job well, no one knows you exist kind of thing. So I definitely understand that idea. Let's talk a little bit about your work with the Department of Corrections and Rehabilitation and Criminal Justice, California Juvenile Justice Compendium. How does that fit into what you've been doing?
Yeah. One of the opportunities that we have for individuals who are incarcerated are two things: reentry services and the medication and services that they have access to, right? So a lot of the providers that CADP represent think about what it's like for that individual to reenter into the community months, years before that person actually is starting to reenter. One of the things that Department of Healthcare Services and Tyler Sadwith at DHCS is working on and has given us as a resource. And, I want to say something before I continue to go. It sounds like I'm name dropping, but part of what I'm doing is appreciating what people in this space are creating, like the tools. I think another aspect of being a good leader is just understanding that like you're a combination of all of this great work that your community has done. So I'm not a name dropper. I do it generally speaking because I really feel like people deserve respect in this space. That being said, we have programs through our waivers that will allow providers to go into correctional facilities 90 days ahead of that person reentering, which is like really exciting, right? Instead of just saying to somebody, because it's a very Hollywood moment where someone, the prison gates open up and they're holding a brown paper bag and they sort of like, they walk out of those front gates and there's a car waiting for them. Like, that's Hollywood. That's not really the way that it works. So the way that it works in California is that providers actually are engaging with people that are, going to re-enter into society 90 days ahead of time, making sure they have a medical home. They have a primary care physician that's helping them, making sure they have a program that they can go to, making sure they have medication, making sure they're connected with family and those kinds of things. So the work that we're doing with CDCR is a bit of a push and a pull because it's new, it's exciting. California is leading the way on these spaces. But at the other point, it's a little frightening because everyone's watching what we're doing. We're the fourth largest economy in the world. And everybody likes to think that, nobody's really watching. But other states are looking at California and saying, well, if they're going to experiment with it and they're going to do it, then maybe other states can do it too.
Mm-hmm. If you could travel back in time to when you were first starting, what would be some of the advice you would give yourself? What are some of the biggest lessons you've learned?
Don't be a footnote in someone else's plan. If you feel strongly about something, you're the one that needs to really take charge on it. I think I mentioned it a moment ago. What's right is right. My grandma Pat will continue to be in my head, and I will think about when I'm in the middle of a situation and I have two decisions, and one is the hard decision and one is the right decision. Like, you have to keep that centered. There's also this old Willie Nelson song, "Don't Let the Old Man In."
Yep.
And I think about that from my health's perspective, but I also think about that from a professional perspective. Just because it's worked for the last 10 years doesn't mean that it's going to serve you going forward, right? You have to let go of the monkey bar behind you in order to get to the next monkey bar in front of you. This is kindergarten 101. And so don't let what has worked in the past sort of stop you from moving forward. There's something that I think about, and I wish somebody would have told me this when I first started around harm reduction, because I thought harm reduction was just about meeting people where they were at. But what I realized for myself, the transformative moment was when someone is drowning, that's not the time to teach them to swim. When someone is in the middle of a chaotic event, whether that be mental health or substance use disorder or any behavioral health event, that's not the time to teach them to swim. It's the time to essentially resource them with things that they need to stabilize. And we can talk about all of the harm reduction tactics and techniques later on. But when someone is drowning, that's not the time to teach them to swim. I recently was diagnosed about a year ago with colon cancer. And so one of the things, and I'm still in my journey of recovery, and I've had my surgery, and I'm here today and super excited about the work I'm doing. So everything is going to be fine. But the one thing that I learned that you can't tell anybody, but I learned it on my own, was second chances saved my life. And I work to make sure others get theirs. The mixture of those things, I really wish I could sort of hand my prior self. The one thing I wish I would have, a lot of bad bosses make you a good boss. So if you're in the middle of your journey around, whether it be substance use disorder or mental health or even banking or social work or whatever you're doing, there's always something to learn around what you're experiencing.
Exactly. Yeah. Back to the whole, I've been in LA for about 10 years now, a little over that. I've worked with 3 startups, and boy, how do they not know how to manage in startups?
Yeah. Well, it's interesting you say that, because I have a good friend of mine, David Begnaud, and we're in 2 totally different spaces. He is wildly successful and celebrated within the TV news space. In fact, he has this great new podcast called The Do Good Crew. And I'll get into that a little bit later on, because it's like my little dose of hope and excitement. And one of the things, because I really struggle with like how to navigate staffing issues and how to navigate just personalities and those kinds of things. And one of the things that he said a long time ago was, find somebody who shares your rhythm. And it's such a beautiful thing if you think about it, because it doesn't mean that you're wrong and I'm right. It means that we just got to find people that we have these commonalities with. And then once you get that rhythm, once we're all rowing in the same direction, we have nothing but opportunity in front of us.
Mm-hmm. There was a sitcom in the 90s, Aaron Sorkin, Sports Night. I don't know if you're familiar with it. I had a great piece of advice for leadership. If you're dumb, surround yourself by smart people. If you're smart, surround yourself by smart people who disagree with you.
Oh, confirmation bias. That's great.
Exactly. And I continually try and do that whenever I'm in a management position. You had brought up harm reduction. Let's talk a little bit more. You said you wanted to talk a little bit more about that. What are some of the biggest things that you feel like are needed in that space?
I think that there are, just like everything in life, different opportunities for different people at different stages of their recovery. So when we have the larger conversation around harm reduction, a lot of people think that we just want to legalize drugs. And I'm using really general terms here because this is their language, not mine. They're thinking we just want to legalize drugs and let everybody do whatever they want. That's actually not harm reduction. So there's a huge education space, that we need to be having around those talking points. Number one. Number two, harm reduction is working in other countries. It has been working. It's not experimental. So there's models that we really could use to think about how can we safely do this to essentially keep people alive one more day to offer them robust community services. Number two. Number three, and I think this is the really important part, is funding. We need individuals who are in places of leadership to think about ways that we can support this work through funding it. Because a lot of the work that is being done right now is being done at the national level in different states, is being done by private foundations. So how can we, once again, professionalize? How can we include this as part of our continuum of care in a safe way that is supported by national models, that is using best practices, but also keeping people safe with the goal of keeping people alive?
That is a great thing. Now, one of the things I like to ask people in there, what is your least favorite or most difficult part of your job?
Being a public spokesperson. I don't like this. I think, Angie, you're amazing. Well, I'm super passionate about it, right? It's really hard for me to feel like people care what I think, because I know that everything, and this gets back to why I'm not name dropping. I'm just sort of like using what other people have taught me. It's because I feel like it's not my own. I feel like we have this gigantic community and they're doing all of these really amazing things. And so the way that I sort of cope with it is I try to sort of crowdsource all of these great comments and this great advice and say, well, I'm just promoting what somebody else has said over here. That's the part that I don't like about it the most, but I do it and I'm learning to enjoy it. When I meet people like you, this feels like a conversation. So I actually enjoy things like this, but talking to the press, it's hard to navigate and I have to represent a certain talking point and that's hard. The most exciting part,
that was going to be my next question.
cool, is really being able to step back with my peers and colleagues and think about what the system could look like and having hand in that. We talked a little bit about the funding mechanisms. We talked a little bit about, sort of these policy things. One of the things that we're doing right now is engaging with the next group of candidates for governor. So we have an amazing governor right now. Governor Gavin Newsom has invested more than anybody else in behavioral health and substance use disorders. Nobody's right all the time and we don't necessarily get it perfect, but he has invested through BCHIP funding and through, I won't go through the whole list, but he has invested significant money into our services. He could do more. That's my job to push the state on doing that. But from my opinion, I feel like he's invested significant amount of time and effort into this. But he's going to be gone. And so what are we doing right now to think about the long-term strategy of what it's going to be like to engage with a new governor? What are we going to think about when it comes to what are we doing to engage with the next group of assembly members or senators? Do we want them to be walking into the Capitol under the dome of the rotunda, and then we're shaking their hand and saying, hi, we're the providers that do substance use disorder? Or are we able right now to get in front of them and say, we're going to help you put together your policy platforms. We're going to help you develop your thoughts and experiences around substance use disorder treatment. We're going to get you tours of these really amazing providers. We're going to take you to places like Skid Row and talk about how we're helping people treat their medical conditions when they're living in a tent. Right? We need to be having these conversations right now. So that's the most important part and the most inspiring part for me is the true sort of pie chart of what I talked about a moment ago around being an actual amazing leader. That's really important to saying, okay, I know this is the issue we have right now. And the short-term goals are to solve these 2 or 3 issues today and this week. But the long-term goals, we need to be doing that too. And that's really exciting for me.
Now, we're getting close to the end of the episode. Unfortunately, I am enjoying talking to you despite not being on the ball today. Let's talk a little bit about recovery capital and what that means to you and your job.
Yeah, I think that when we're approaching people from a whole person approach, there's 4 main buckets when I think about recovery capital. And so that's obviously personal, family, social, cultural, and community. The way that we think about or I think about how this all should work is each one of these items really should be supporting each other. So personal is health, skills, financial, self-esteem, families, intimate relationships. When we think about community, those items really should help support individuals through the other spaces. So activism, I think, is really key when it comes to self-esteem. The peer-led movement, it really is around the, do one, teach one mantra that really is around teaching people skills, which leads into the personal recovery capital space. Peer employment is something that we all need to be better about. Like I said earlier, the person closest to the problem is closest to the solution. I also think the nothing about us without us space is really important here. Additionally, individuals who have lived experience need to be able to pay rent and they need to be able to feed their families. And one of the keys to that is professionalizing individuals who have lived experience in spaces and also career laddering. So if you think about an individual that has a chaotic event, finds himself in recovery, and eventually works in the behavioral health space, how are we going to create an opportunity for individuals that they can be a peer support specialist, that can move into a social worker, an LCSW, maybe into an MFT. And so we need to be really thoughtful around that. And we talked a moment ago about just the full spectrum of services for providers. But I think a full spectrum of services from the self-esteem perspective with people who have lived experience or are receiving services with SUD. They want that so they don't have to basically eject out of their own community to be able to go receive services someplace. So if somebody is trying to receive inpatient help for a substance use disorder, whether that be alcohol use disorder or opioid use disorder, they should be able to go into a facility. They should be able to partner with that facility to be able to receive all the services they need without having to go to this program, that program, going to the county, across county lines. And so I think the full spectrum of services is really important here. The reason that I'm saying all of these really important details is not because it's unnecessary detail for recovery capital. It's because the system really needs to be matching the strengths from a strength-based approach for the individuals.
Yeah, that definitely makes sense. Our audience is kind of wide ranging, but I always like to ask what kind of resources you use on a regular basis to kind of keep updated with what's going on in the industry, how you stay on top of everything. You mentioned the Do Good Crew podcast. Did I get that right?
Yeah, it's dogoodcrew.com, I think.
Okay. What other resources do you use to kind of keep updated with what's going on?
Yeah, I'm involved in a lot of local groups. We belong to a larger national association called TCA, or Treatment Centers of America. If you get on their website, they will be happy to share with you resources when it comes to like the larger national perspective. They have newsletters that you can keep in touch on what's happening from a substance use disorder perspective at the national level. I have an amazing staff that, quite frankly, put out significant SUD focused updates. So if you go to CADP.org, you will be able to keep in touch on some of the work that we're doing. And that could be in-person events where the department and elected officials are coming and talking to people about SUD-focused issues. That could be newsletters. We also have social media channels that you can keep in touch with. It's just CADP at whether that be Instagram or Facebook or whatever. I think LinkedIn is a tremendous resource. I'm on LinkedIn. If any of your listeners are on LinkedIn, let's connect. If you have topics you want to discuss, that's super, super, super important. Like I said a moment ago, the Do Good Crew is something that I feel really strongly about, giving me hope in a meaningful way. Mm-hmm. And we need more of that right now. With everything that's going on, we actually really just need more of that right now. And so those are a couple of the resources. Also, don't forget sudvoices.org. That's something that will help people keep in touch with the larger consumer movement in California. But nothing substitutes just conversations like this.
You've already mentioned this a little bit, but for those who may not be reading the show notes or may not be seeing this online, how can people get a hold of you? Please spell websites.
Yeah, CADP.org, CAADPE.org, SUDvoices.org, but I'm also on LinkedIn as Robb Layne, ROBBLAYNE.
Okay, to the last question, and it's kind of a reiteration of my first question, but what I like to do is gut reaction, no preparation, no thought. Why do you do what you do?
I just keep returning to the idea of lifting up community voices, helping people get the services they need to keep them alive if they're in the middle of a chaotic event, and promoting the work of the people that are saving lives. I shared a moment ago about it's not just enough anymore to do the good work. You have to have people out there telling individuals, telling elected officials, telling state leaders, talking to the news about the work that we're doing. I feel like that's the part that gets me going in the morning. And, I'm just so grateful for our board at CADP. I'm grateful for the staff at CADP. I'm grateful for our state partners. It's been a wonderful experience. And I'm just really looking forward to seeing what we can do over the next few years.
You've been listening to Destination Change. Our guest today was Robb Layne. Thank you for being here. Our theme song is Sun Nation by Kitsa and used via a Creative Commons license by the Free Music Archive. Please consider rating and reviewing the podcast on Apple Podcasts so we can get more listeners. In the meantime, you can always see more about the podcast, including show notes and where else to listen, on our website, www.nbhap.org. If you have questions for the podcast, please email us at info@nbhap.org. Thanks for listening.